Hi there, I'm Leah, nurse practitioner with Affiliated Dermatology, and I was asked to speak to you guys all today about caring for your skin as you age. So my objectives are to review how the skin changes with age, review the types and signs of skin cancer, overview some of the common skin concerns of older adults, review some sun protection strategies, and why and how to get elders dermatology care. Some disclosures. I am an employee of a private local dermatology group, Affiliated Dermatology. I was not paid to give this presentation, and I have no drug or product affiliations. So let's start with some skin basics. You might not think of the skin as an organ, but it's actually your body's largest organ. And skin cancer is the most common form of cancer in the United States. That's all of the skin cancers combined. Quite common. 1 in 5 Americans will actually develop a skin cancer in their lifetime. And on average, one person dies from melanoma every hour. The good news, skin cancer is highly treatable when detected early. Pop quiz, just making sure everyone's awake. Arizona is number 2 in the world for highest rates of skin cancer, behind only who? So who's number 1? Who gets that lucky classification? Dun, 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 dun. All right, Australia. So we're behind only Australia, and that's for anywhere in the world, above all the other common sunny states, Florida, California, etc. Ooh. There we go. Can't find my mouse. So some changes with aging. As you can see here, the top layer of the skin, that's referred to as the epidermis. Here in the dermis, or the lower level of the skin, is where you have a lot of the blood vessels, the hair follicles, the nerves, and then down below that is your subcutaneous or the fat layer. So as we age, our skin undergoes changes that weaken our defenses against skin conditions. Some of this will happen to all of us. So no matter what we do, that's the intrinsic aging. So reduced immune systems, poor healing capacities, thinner skin. The skin loses fat and water content and becomes thinner, which allows the UV light to penetrate more deeply. Some of these changes can be made worse by things we do over the years. So things we do have control over, extrinsic aging, or the external factors from bodily assaults, such as smoking, UV damage, and pollution. And all of these increase our risk for skin cancer. So what are the types of skin cancer? We have actinic keratosis, often called AKs. That's this one in the middle here. And about 10 to 15% can go on to become squamous cell carcinoma. These are often just dry spots that maybe go away, but always come back in the same spot. They can be like rough to the touch and more easily felt than seen. The 2 types of non-melanoma skin cancer are basal cell and squamous cell. This one in the top right there, and then squamous cell. They're the most common types of skin cancer and most commonly occur in sun-exposed areas such as your face, your ears, your neck, your lips, the back of the hands. They can be faster to grow or slow growing depending on the type, mostly slow growing, but they rarely spread to other parts of the body, unlike melanoma, which is the most dangerous, the most common, or the least common, sorry. Less than 1% of skin cancers are melanoma, but the most deadly. So let's review each of those a little bit more closely. Actinic keratosis. You can see that this man's hand, we would call this chronically sun damaged. All of these are little precancer spots. This one might even be a little early, superficial squamous cell. For precancers, they occur on sun-damaged skin. They increase the risk for non-melanoma skin cancer. Treatment for these would be local destruction, such as freezing, if there's just a few, or more like a topical cream for this guy, or photodynamic therapy, which results in like a series of treatments, kind of do some field therapy where we can treat larger areas, reduce the risk of developing a skin cancer. Non-melanoma skin cancers, as I said, are the squamous cell and the basal cell being the most common. These can look like flesh-colored pearly bumps, a pinkish patch of skin, larger nodules, what we call a bump bigger than 1 centimeter, that ulcerates. So you can see here kind of this one's been bleeding. Squamous cell carcinomas can look, they vary a lot in how they look. They can look like a wart, a rapidly growing like tender bump, little skin horn, sore that won't heal, larger bleeding, draining lesions. Treatment, sorry, go back real quick. Treatment of those squamous cell and basal cells most commonly is just removal of the actual lesion, results in cure. That can be done by, sometimes if it's superficial, with freezing and followed by a topical chemotherapy cream. There are surgical interventions such as electrodesiccation and curettage, where we kind of scrape and burn. Excision, just cutting out. A special type of excision called Mohs, that would be used for like these larger ones, especially on the face, where we want to minimize how much tissue we have to take. So they would cut out what they visibly see as skin cancer, check it under the microscope while the patient waits. And then at like 3 o'clock, if there's still a little skin cancer, they'll bring them back, cut a little more, check it again, etc., until they're sure they've got it all, and then they close up the patient. And there's also SRT, or superficial radiation therapy, which can be used for these types of skin cancer, especially if they're in maybe in a very cosmetic area, such as on the nose, on a lower leg, in someone that is on chronic anticoagulants that can't stop them. So there's high risk for bleeding, things like that. Melanoma, this is the one we're always trying to prevent, also known as malignant melanoma. There are 4 types of melanoma: superficial spreading lentigo maligna, acrolentiginous melanoma, acro referring to hands or feet. You may have heard, this is what Bob Marley died of, melanoma on the foot. And there's nodular melanoma, which is the most fast growing dangerous type. This can be deadly because they can easily invade other tissues and spread to other parts of the body. If caught early and they're superficial, cure rates are very good, or survival rates, about 99%, 5-year survival. They're just localized. If they have metastasized to local areas, such as maybe a melanoma on the arm has gone to these regional lymph nodes, 5-year survival is about 65%. And then if the metastasis has gone more distant or widespread, the survival rates can be as low as 25% for 5-year survival. Melanomas can develop from a mole you already have, but most commonly they develop out of an area of previously normal skin. So what puts you at risk for getting a skin cancer? The more UV light you're exposed to. So this not only involves your amount of exposure or how much time you spend outside, but where you live. Obviously, if you work outside, if you're using tanning beds, having fair skin. So those with fair skin have less melanin. Melanin protects us from UV light. Being of older age, not only having decreased capacity to heal and fight those abnormal cells, but also they've just been exposed to more sun. Men in general have a higher rate of skin cancer, so 2 times higher rate of basal cell and 3 times higher rate of squamous cell. Previously irradiated skin is high risk for melanoma, as well as a history of breast cancer. Having a previous skin cancer puts you at risk for having another. And then having a weakened immune system, especially those who've had solid organ transplantations. Smoking puts you at risk. Genetics plays a part, especially with melanoma type of skin cancer. And then having certain types or large number of moles also can predispose you. Dry skin. One of my most common complaints I get from patients, but not just older adults, even in the clinic, probably 1 in 3 patients, we end up talking about dry skin while I'm looking them over. Very common, especially in the winter, especially in Arizona. We have very dry air. We all know what dry skin looks like. Can look flaky, dull, feel rough. Can be especially problematic for seniors because, as we discussed, that top layer is thinner, which really limits the ability to hold moisture. They have less natural oils on their skin, less skin cell turnover, and maybe on medications such as diuretics, which can worsen this problem. So you might be thinking, why am I talking about dry skin? It's just dry skin, who cares? It's not a big deal. It can be a huge issue because itching or the dryness can lead to itching, and itching can lead to scratching, and scratching can lead to infection, chronic skin problems such as lichen simplex chronicus, big word you don't need to remember, even swollen eczematous skin. When the skin kind of gets that breakdown from being so dry, it's more predisposed to getting environmental allergens. So it's like getting contact allergies from soaps because they have like dry skin with more cracks in it. And then pathogens like bacteria can get in, cause cellulitis, infected lesions, things like that. Things to do. Oh man, I can't tell you how many times I go in to see an older adult and we're talking about dry skin or a rash, and I go look in their bathroom. So I do mobile visits, we'll get to that, but and they have Dial bar soap and like lavender scented Gold Bond lotions. I'm like, oh no, 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 no. So no bar soaps. Avoiding use of really soaps. We want to use like fragrance dye-free cleanser, so like a creamy fragrance-free cleanser like Dove Sensitive, things like that. Avoiding that hot water, so really like cool, lukewarm, keep it short, are all good things. And then like right after showering, really within like those 3 minutes, you don't want to scrub off all the water, or in the shower for scrubbing for that matter, use a soft cloth or hands. When you get out, just patting the skin dry, leaving on a little bit of moisture on the skin, and then using fragrance or dye-free creams such as CeraVe or Cetaphil. Honestly, the thicker, the greasier, the better. Comes in a tub, great. If it's in a pump, oftentimes it's too thin to do too much, have too much benefit. Or to have to apply, you have to apply it a lot more often. Other things you can do, use a humidifier, drink enough liquids, that's huge, and then smoking can also worsen the dry skin. I have an example here of just how bad dry skin can get. I was actually consulted for this patient. She was actually having psychosis, like screaming, can't sleep, having delirium because she would be up all night itching and scratching at her skin. As you can see, it got quite bad, and some of these were like on the verge of getting infected. She's very miserable. Itching can be a very, very distressing symptom. I'm sure you might hopefully have never gotten to this point, but we've all had a bug bite or maybe gotten into poison ivy, and just, you know, how it can be hard to focus on anything else. So just think of what that can be, especially for like an older adult, can really limit their quality of life. And simple interventions can have a huge difference. So this was just a month later after I saw her, using just a topical corticosteroid with an emollient. So emollients would be like Aquaphor, Vaseline, and having them trim her nails made a huge impact. As you can see, oftentimes that can be a problem with cognitive impairment as well. Is just that they have nothing better to do, so they're kind of just sitting there scratching at things. If you can keep the skin moisturized and limit like the initial trigger to scratch, and then keep their nails trimmed, can make a huge impact. My husband always teases me that he could be a dermatologist because everything I tell everybody to do for everything is just Aquaphor, apply Aquaphor. I do love the stuff, but emollients are great for very dry skin. Bruising. This is a common complaint as well. Unfortunately, sometimes avoidable. Really with this, like the goal is just to prevent it and treat underlying causes. Many things that predispose older adults to this: the gradual reduction in the number of blood vessels, the elastic fibers, the loss of collagen and fat. So we just don't have as much protection from external trauma. A lot of times it's like such a minor insult, such as like bumping it on the table or pulling on your shirt roughly, can cause the bruise. So patients are saying, I'm bruising for no reason, which the reason is just so minor, they don't never realized it. These types of bruises should resolve within 3 weeks. They can be significantly worsened by chronic sun exposure, which is kind of a different type of bruising called solar purpura, which is where just chronic sun damage over the years has just made those vessels so fragile that they just more easily rupture and then leak under the skin, causing the appearance of the bruise. Many older adults are also on medications that can decrease platelet count. Coumadin, Plavix, aspirin, even ibuprofen can all worsen this. And then obviously doing wound care if they do get a tear. Patients are often asking, what can I do? Really the biggest things is preventing the trauma. So I'll say to some of my more active older adults, like if they're gonna work in the garden, cut off a sock at the end of like the heel and wear like a long sock from their wrist to their elbow, which can help like prevent cuts and scrapes. Wearing gloves when they're cleaning, like taller gloves, protect, like wearing longer sleeve shirts when weather appropriate, keeping the skin moist, as we talked about in the last couple slides, really using like ceramides that are in like those CeraVe Cetaphil to repair the skin barrier, and then avoiding sun. There are some expensive gimmicks out there that claim to help this a lot. One I know of is like Dermament. It has some arnica in it, which is used for like cosmetic procedures if people are getting Botox or fillers. It can speed clearance. I wouldn't say that it's probably worth the money. So chronic venous insufficiency just is referring to poor vasculature in the lower legs, mainly. As we age, or it can be in young people too, but the causes: prolonged standing, can be hereditary, previous history of blood clots, obesity, heart failure, all can worsen this. Symptoms would be edema or swelling. You can see here on the picture, that's called pitting edema, when you press it down and you let go and it doesn't pop right back. Varicosities are kind of those enlarged vessels. Brown discoloration, we call that hemosiderin staining. It's the heme that's in your blood. When it pools down there, it leaks out of the vessels and stains the skin. Dermatitis, so like kind of the skin getting red, dry, flaky, thickened. And you can have ulcers. Treatment for this involves elevation, exercise, compression stockings, emollients, again that Aquaphor, topical prescription creams, mostly steroids, and then sometimes surgeries. This is a pretty graphic example, so sorry I didn't warn you. This was a very severe flare. This is pre-treatment. This is 2 weeks after treatment with topical steroids, compression, elevation, and bleach baths. We use diluted bleach and soaking the whole leg in there can really help to not only cut down on bacterial load, but also kind of like dry it up and prevent or like resolve a lot of that oozing. Works great. Let's, a couple other skin problems I added in here that I've seen, unfortunately, can be a huge problem, especially in facilities. Scabies can be extremely contagious. So please, please, please just be on the lookout for it, educate show your staff pictures. I've seen a couple cases where patients, multiple, within like one small area of this facility had been itching for months, 4 to 6 months. It's miserable. Patients that come in that are mentally competent will be literally like, I'm gonna lose it when they have scabies. It's extremely itchy. A mite kind of buries under the skin, causing a hypersensitivity reaction. Itching is worse at night. It's most common in hot areas. So like in between your fingers, as you can see there in the picture, along like the volar wrists here, on women around the nipples and areola, and then men like along their waistline and even in their scrotum is where these can most commonly populate. So please don't always assume that itching is just from dry skin or that itching is just from old age. There can be causes, and these poor patients really suffer. Scabies does require environmental eradication in conjunction with treatment, which is huge and important, and obviously like limiting, isolating patients that have it to not result in a widespread breakout. Another common problem, shingles. You guys may have, people in this room may have had, or at home, no one's in the room, I'm here by myself. But you guys may have even experienced this for yourself. This is a reactivation of the latent varicella zoster virus, or chickenpox, which remains dormant in our nerves and then can become reactivated with many things that are common, unfortunately, for older adults. Immunosuppression, stress, other illness can reactivate this. You can see here on the picture, we refer to this as dewdrops on a rose petal. So it's kind of like blistering on a red background. The quick treatment with antivirals can really minimize the likelihood of postherpetic neuralgia, which can be like long-term pain in that area where the shingles did occur, which can be devastating. One thing I would just mention about this is just a quick tidbit on shingles, but if it is on the face and especially on the tip of the nose, that's called Hutchinson's sign, and that should be emergent because it can be involving the eye, which can result in blindness. So should be dealt with as quickly as possible. All shingles can have like a little prodrome period, maybe like a day to 3 days of be feeling tingly or itchy in that area, and most often the rash is accompanied by pain as well, sometimes itching. Benign spots. I say benign, meaning they're not harmful, but they can be very harmful to the psyche cosmetically for a lot of patients. I don't know who comes up with these names. Skin tags, as they're more commonly referred to, scientifically would be called acrocordons. They are these little fleshy, skin colored or a little bit darker growths that are called pedunculated or kind of hanging on there by a thread, most commonly occurring in areas of friction. So on the neck, under the arms, in the groin, barnacles, as their nickname, or seborrheic keratosis, I always call them SKs. They're little excessive growths of tissue that occur with age, genetics, friction. They can be very distressing to people, and oftentimes this is what gets them into the office, and then we find skin cancers or other things that are more concerning, and then just have to reassure patients about these spots. Liver or age spots have nothing to do with your liver. Solar lenticle have all to do with sun. Sun exposure can result in these kind of irregularly shaped, usually all one color. How you differentiate them from a harmful mole in sun exposed areas. So on the face, on the back of the hands, most commonly. These spots don't need to be treated, any of these, but can be for cosmesis, or for, they can be irritating. A lot of these SKs will sometimes get pretty itchy, things like that. So they can be treated with freezing or cryotherapy, cutting them off if we have to, lightening creams for these sunspots. Let's talk a little bit about sun protection. A lot of times we'll have patients coming into me saying, the damage is done. I worked as a farmer for years. I never wore sunscreen, or any whatever they're telling me their backstories are, but it's never too late to reduce your risk for skin cancer. We all know the common things to do. So wear sunscreen, sunglasses, seek shade during those peak hours of 10 to 4, wear UV protective clothing. So in addition to causing sunburn, too much UV exposure can also cause changes to the skin texture and cause the skin to age prematurely. So if you don't care about skin cancer, maybe you care about wrinkles. That's a reason to do it, to protect your skin. UV rays have also been linked to eye conditions such as cataracts, so make sure you are protecting those eyes as well. And then obviously avoiding tanning booths. And we're going to talk a little bit more about sunscreens in the next slide. Just remember that having a suntan or a sunburn means that the skin has been damaged. So a little bit more on sunscreens. I've done this presentation for a little while and I had to actually add in a slide on this because last year the FDA came out with some data regarding safety of sunscreens and prompted a lot of questions. So there's actually 2 different types of sun protection that we apply to our skin. So sunblock would be the physical sunscreens. It may leave a white residue. They sit on top of the skin and prevent the UV rays from hitting the skin at all. These would be the ones that contain the active ingredients, zinc oxide and or titanium dioxide. They do tend to be better for sensitive skin. Chemicals, sunscreens or sunscreens absorb quicker. They're not as visible. They kind of go sit under the skin and change the wavelengths so that they don't cause damage. They contain chemicals such as the ones you can't pronounce, AVO or oxybenzone on the active ingredient list. A recent FDA study in May of 2019 did show there is some systemic absorption of these chemicals, and what problems that may cause has not been researched yet. But if you're worried about that kind of thing, better to probably stick with physical sunblock. And this category of sun protection would be the ones that you hear in the news about being harmful for the environment, the coral reefs, etc. Some people will always ask me my preferences or what are the examples of brands. Sunscreens would be like the common ones you think of, Coppertone, Banana Boat. Sunblocks would be more Elta MD, Blue Lizard, Sensitive, Neutrogena Sheer Zinc. So if it mentions mineral sensitive, it's probably a sunblock. In the end, really just comes down to wearing at least a 30 SPF. 30 SPF blocks 97% of the sun rays. So people tell me, I'm wearing 100, isn't that good? I'm like, great. As long as it's 30, like that's all. 100, I mean, maybe you get 98%, but kind of moot point over 97. You want to make sure it's broad spectrum. So that means that it's blocking both UVA aging and then UVB, I think that is burning rays. And then don't forget to reapply. 30 SPF, or the SPF factor, refers to sun protection factor. So a 30 would mean you can stay in the sun 30 times longer than you could have before you burn than if you weren't wearing sunscreen. So what do you do to prevent skin cancer? Get your skin checked. We recommend everybody, especially in Arizona, get yearly skin cancer screenings. There are spots you can't see. There are things that you aren't looking for that a trained eye can find. We do recommend that everybody be familiar with the skin you're in. So doing those monthly checks, knowing where your biggest, baddest moles are, if they've changed. The good news is that Medicare, as well as most other insurance companies, will pay for annual skin examinations. And then if you have a history of skin cancer or family history of skin cancer, we might recommend more frequent screenings. So what are you watching for when you're doing those self-checks? These are the ABCDEs of melanoma. Doesn't necessarily apply to those non-melanoma skin cancers. A is for asymmetry, so one half is not like the other half. B, border irregularity, so kind of not quite smooth border, maybe jagged. Color, having more than one color, or being very dark. Diameter, hopefully we're finding them before this, but more likely to be something bad if it's bigger than 6 millimeters or end of a pencil eraser. And then E, evolving or changing over time. Not all skin cancers look the same, so if you notice a change and you're not sure, come see somebody about it. The more non-melanoma skin cancers are more things we talked about, like scaly spots that aren't going away, sores that don't heal, red spots that kind of pop up and maybe be a little tender. Yeah. I like to add F to this ABCDE mnemonic. F is for funny looking. So I like to tell my patients that have a lot of moles, like, how do I keep track? How do I monitor all these moles? They say, just look for the ugly duckling. So maybe one that doesn't look like the others. And that's part of many things that we're looking for when you come into the office as well. Everybody can have like their normal mole. We're kind of looking for something that doesn't fit the pattern. Oftentimes, patients will find their own melanomas this way. So a little overview on why seniors are at greatest risk for skin cancer, as well as these other skin conditions I talked about. They have so many predisposing factors: the decreased mobility, which can impede vascular efficiency, their decreased immune response, reduce the body's ability to heal, numerous drugs such as diuretics, causing those dry skin and drug rashes. I see so many drug rashes in older adults, so just keeping track if you do have a resident with a rash. When did the rash start? I'm sure logs say when medications were started and stopped. That can be very helpful in kind of trying to figure out when exactly or what drug caused a rash. And then the increased incidence of chronic disease, atherosclerosis, or vascular disease, diabetes, HIV, CHF, all of these can negatively impact the skin. The modifiable factors, their nutrition state, so making sure people are getting enough protein, water, staying hydrated, and then personal hygiene, helping them apply those lotions, as we talked about, using those fragrance and dye-free creams, making sure people are staying clean and dry, can really help avoid skin breakdown. So just really advocate for your residents and educate your staff to help patients get annual skin checks or get concerning lesions, unresolving rashes evaluated. So a little bit more about what I do. I came to Affiliated Dermatology to start an out-call program, which is where we provide mobile dermatology services in the community at assisted living, independent living, memory care, group homes, really trying to bring dermatology care into those places for patients that may find it hard to come in to see us in the office. Maybe they just don't drive and it's hard to get around, might be in a wheelchair, maybe there are cognitive impairments that make it difficult or require multiple caregivers to be with them, to take them out of the office. Seeing them in their environment is much more comfortable for them, among other issues. We were seeing that many mobile primary care providers do not have the tools and capability to biopsy concerning lesions out of the office. Oftentimes they encounter rashes that they can't figure out and don't have anybody else to refer to. And I see this a lot, just families being overwhelmed, taking care of more pressing health needs, and dermatology often gets postponed. These patients do often have history of skin cancer and should be getting routine checks. So when I come into the facilities, I can do almost anything. Besides surgeries, I can do biopsies of anything that looks suspicious, evaluate rashes, treat precancers, provide prescriptions, etc. And I will work with the families with the power of attorneys, really to discuss either before we do a biopsy or even after, once we find out what it is, factor in their goals for care, their life expectancy. Oftentimes what I'm doing for these larger lesions, maybe the patient isn't appropriate to come to the office, and that would be a huge ordeal. Oftentimes just cutting it flat with the skin, or what I refer to as like a palliative removal, is all the patient and the family wants. Now it's no longer bleeding, they're no longer picking at it. It's not cured, the cancer's not gone, but oftentimes that's all they're really looking for. So I guess that would be how I'm different than if you came to the office. Yeah, most of my referrals come from mobile primary care physicians, providers, NPs in the community who see a patient in one of your facilities and then refer me for whatever reason. The patient's requesting it, the family's requesting it, there's a rash they can't figure out, there's a new mole they've noticed, or the staff has noticed. I also have some relationships with the facilities themselves that just want to provide that extra service for their residents. So some facilities I am routinely at, I will have like an established day where I'm there the second Tuesday of every month, and patients can schedule to visit with me through the facility. And then I just come and see like 5 or 6 patients. That works really well as well. You guys, can reach out to me. This is my contact info to send referral information or just reach out to me for more general information. I have done some educational stuff at a few communities. Willing to do that as well. You can reach out to me at this email address, and this phone number is my direct number for work. Bad timing, but I should mention on here, by the time you guys are watching this, I will be like 8 months pregnant. So I will be on maternity leave for the end part of the year, but I do have several weeks before I'll be out. So reach out to me sooner rather than later if I can get you information. And I will be joining you guys here live to answer some questions. Thanks for having me.